Thank you. Dr. Pan? Okay, thank you very much. We'll be following this one with great interest. Number 17, please.
Of course. So within the governor's proposed budget, we are proposing to invest $400 million total fund, $200 million general fund over 3 years to increase the number of kinder through 12 students receiving preventive early intervention behavioral health services offered by school-affiliated behavioral health providers. The funding would be distributed via incentive payments through our Medi-Cal managed care plan. So essentially, the department is proposing to have a robust incentive program through managed care to really look at increasing access to services. It would pay for infrastructure, partnerships, and capacity building. We do allow for a variation in regards to the types of incentives. It could include, for example, three-way contracts between our Medi-Cal managed care plan, counties, and school districts. It could pay for planning services for how do we increase access to behavioral health services in schools. It could play for telehealth portals or billing portals in schools to be able to increase access to those types of services. I would just note the proposal is specifically for infrastructure, capacity building, et cetera. Services can be billed directly and separate outside of this. The main reason we are proposing it go through the Medi-Cal managed care plans is our Medi-Cal managed care plans are responsible for the non-specialty mental health services provided to children, which is dominantly children are going to be needing non-specialty mental health services. We know that our county partners have made large inroads in regards to partnering with school districts to get specialty mental health services in place. And we are really wanting to ensure that we're looking across the full continuum where we pay our Medi-Cal managed care plans to provide the non-specialty mental health services so that all children can receive behavioral health services in schools. And we think that is really important to maximize. While our current focus is also focused on increasing access to Medi-Cal behavioral health services in schools, we do hope that by putting in the infrastructure like the billing systems, the data sharing systems, the technical assistance that's needed for the school districts to be able to understand how to better bill Medi-Cal services and interact with managed care plans, that we'd be able to increase access to all Medi-Cal services on school-based services in the schools. We also think that by investing in these infrastructure and capacity building with school districts, that it would impact non-Medi-Cal kids and really allow for, while Medi-Cal is 50 to 55% of all kids are on Medi-Cal, there are non-Medi-Cal kids that could greatly benefit from school districts being able to bill and provide services to those other payers in the school district. So we think that is an outcome that would greatly benefit all children across the school. We do also know that this is, we're hoping this will be braided funding and collaborate with other kind of funding streams that are flowing in this way, whether that's MHSA or other dollars that the school districts have. We plan on providing extensive technical assistance to make sure that it is complementary across the Medi-Cal managed care plans, the counties, LEA BOP, as well as other MHSA funds. But we do think it is an important investment to make to ensure we're increasing access to Medi-Cal services in schools. To be able to do this, DHCS is requesting limited term resources equivalent to 12 positions with the funding expenditure of $11 million total fund to be able to implement this particular proposal. And happy to answer any questions you may have.
Thank you. Department of Finance?
No comments at this time. Thank you.
LAO?
Thank you, Senator Eggman. Corey Hashida again with the LAO. Again, we recently published an analysis of this proposal on our website, and I'll just sort of give some brief remarks touching on some of the main points that we raised. First, we would just note that similar to the last proposal, the continuum infrastructure proposal, there are some substantial details related to this proposal that, to our understanding, are not sort of fully fleshed out at this moment. This would include, for example, the specific allocation methodology that would determine how the incentive payments would be distributed to managed care plans. And our understanding is that the administration is also proposing to rely on the budget bill process to establish this incentive program as well. And we suggest the same sort of like trailer bill approach that I discussed earlier in the continuum proposal. When it comes to the intent of this proposal, we don't raise any issues with the concept of increasing managed care plans footprint in schools. We do find that it's unclear whether the amount provided in incentive payments will actually induce managed care plans to invest in these partnerships. And the legislature may want to ask the administration how it determined that this funding amount would be sufficient to sort of change plan behavior and induce the desired partnerships being created. In addition, we find that the real challenge with this proposal is going to be navigating the very fragmented behavioral health delivery system. Students can access Medi-Cal behavioral health services through several different entities. It could be a county, it could be a managed care plan, it could be a school directly. And the administration touched on sort of the dividing line between specialty mental health and non-specialty mental health between counties and managed care plans. But which entity is responsible for what service through Medi-Cal can often be determined inconsistently. And in addition, counties may also provide sort of the same services that managed care plans could provide under their non-specialty mental health responsibilities and just use their local funds instead of paying for the services through Medi-Cal. And so all of this is to say that this proposal really highlights the need for the administration to clarify exactly what service gaps managed care plans could fill under this proposal. And it really also sort of highlights the need for a comprehensive state effort, even thinking more generally outside of this specific proposal, to coordinate these different entities together to ensure that A, all the services that students are entitled to through Medi-Cal are being provided, and B, that no duplicative services are being provided by either counties or managed care plans. We would also raise that there are a couple of other proposals in the budget related to student mental health. There's a proposal to provide MHSA funds to support a state grant program to, sort of support county school partnerships. And there's also a proposal to provide Prop 98 funds to schools in order to match county student mental health activities. And so this coordination issue that sort of brings up the coordination issue again and sort of raises the issue that it's sort of unclear how this proposal will sort of interact with those other proposals that are in the budget.
Thank you very much. So Director Cooper, I guess we all I think agree with the idea of increased behavioral health services in schools and to our young people, and I believe this is an attempt to try to provide access and streamline things. But how do you respond to the issue that in some ways it just makes one more level of confusion and potentially duplicative services and not a real clear path about how somebody gets care?
I think what I would say there is that the Medi-Cal managed care plans have a clear responsibility to provide the non-specialty mental health services to children. And while I clearly understand that some counties may choose to use local funds to provide those services, we are already paying the Medi-Cal managed care plans to do this, and we hold them accountable to it in the capitation rate that we pay them. And so it would be more prudent for us, since we are already paying the managed care plans through that, for them to be ensuring that children are getting access to those services. And I think with this proposal, we're trying to look a little bit more upstream in regards to making sure that kids are getting access early. And we do think that there is an opportunity with this to better strengthen the relationships between the Medi-Cal managed care plans and counties, because they do have a shared responsibility for providing mental health services as a whole between the two of them to both children and adults in California. And so we do think that there is still a huge opportunity. For example, today within many of the behavioral health services provided in schools, whether through LEA BOP or specialty mental health, it oftentimes is only really provided for individuals with special education services, or when it's in the IEP, depending on which portion we're talking about. And there are counties who have expanded to the non-specialty side too. even though ultimately that responsibility is the managed care plans. However, we want to make sure that children have access to their full rights under EPSGT and under Medicaid to all behavioral health services and all Medi-Cal services. And so by getting the managed care plans into the schools, while we do need to have better coordination with our county partners, it also allows all of those other non-behavioral health Medi-Cal services to be available for those children in the schools as well. So there is that additional opportunity with leveraging these dollars and putting the infrastructure in place so that school districts can remove those barriers. We've heard for a long time that everyone wants to be in this space, but they can't do it because they don't understand how to bill Medi-Cal. They don't have the data systems to do it. They don't have the billing systems to do it. And so these incentive dollars are really meant to remove those historical barriers that we've heard to be able to get in a space where children can maximize their full Medi-Cal benefit and not just a very small portion, which is currently being provided today.
So if the plans are already supposed to be doing it, why aren't they? And why do we think this incentive is going to be enough to incentivize them?
It's really the pieces I was talking about earlier. You know, it is complex, just to be clear. This is not easy to do. But we've heard, you know, school districts historically have had challenges understanding, you know, whether it's negotiating with the managed care plan, how to bill, having systems that allow for them to bill and be reimbursed for services, et cetera. And so that's why these funds aren't for the services. That's already built into our budget today in regards to the capitation rates going out. This is really to do the actual infrastructure necessary. So if they want to convene, plan a school district and county to have a planning process to figure out how they're going to increase, the incentive dollars can pay for that planning effort. It can pay for technical assistance to come in to help move the needle in this space, or to put in a billing system or a data sharing system, or a telehealth portal that could be in the schools that allow for those services to be easier accessed. So it's really paying for that infrastructure partnership and capacity building, which is what we have historically heard are the main barriers for both managed care plans who want to get in this space and school districts to kind of get over those humps. Instead of just covering it with local funds, we should be maximizing the federal dollars that allow for us to draw down here, as well as the dollars that we pay our Medi-Cal managed care plans in this space. And so it's really about being prudent with the funds that are in the system and then leveraging it to be able to draw those down. So that's why we think the incentive is good, because it's removing some of those historical barriers for why people have said they have not been able to move into this space.
Thank you. Dr. Pan?
Thank you. I appreciate this proposal. I should just, first of all, preface my remarks by saying that I used to be medical consultant for a school district, and been very involved in school health issues through my professional side, American Academy of Pediatrics, and so I have some practical knowledge, and I appreciate this effort. So I guess my first question is that will you have a mandate for every for the managed care plans who participate in Medi-Cal to contract with every school district in their region? Because after all, the school districts don't want to, and I want to point out, school districts are educational institutions. They don't have, and there's 1,000 school districts, by the way, over 1,000 school districts in the state of California. And maybe some of the larger ones do, but generally, they're not interested in hiring a bunch of staff to negotiate managed care contracts. I mean, let's just be blunt about it, right? So that's not going to have that in. So it actually behooves the managed care companies to establish, and maybe there's a standard contract or something that you develop in conjunction with the Department of Education. But I would say, first of all, is there a requirement that the managed care company have to have a contract of some sort, and you can develop a baseline contract with every school district in their region that's in their service area, so that they are compelled to actually talk to the school districts, because you can't expect the school districts to go try to find a managed care plan. They're busy trying to teach kids.
So with this current proposal, what we have in here is that we would pay a higher incentive to managed care plans that have a higher percentage of school districts in their service
Okay, all
area.
right, okay. So my question is, are you going to require them to?
So with
Yes or
these
no?
incentive dollars, the answer is no. We're not
Okay,
mandating
all right, so-
all of them.
okay.
However, if I could, we are considering within the procurement in the future to ensure that plans that are coming into California understand that the future expectation will be that managed care plans in California do commit to and attest to committing to those contracts to provide services in schools.
All right, so I just want to look at it also from the perspective of the school district, right? So what happens is that for the school district, generally they're somewhat reluctant to say that this set of kids get these services and that set of kids doesn't. Now, certainly they do have differences like free and reduced lunch, et cetera. Although again, when you have a high percentage, we generally, so you can imagine a school district that's being serviced by, the two-plan county, a GMC county, or some other, that there are actually multiple Medi-Cal managed care plans. And the problem is that one plan decides to contract, the other one doesn't. And they're sitting there having to sort out and tell this kid who's on Medi-Cal, nope, sorry, we can't do that because your managed care plan didn't. Sorry, you. And so it gets them into this bind, and generally, if they can't get all of them, it's really hard as a school to say, you know what, if you're on Medi-Cal, but you have to be on this plan, then we'll provide these services to you through our school. But if you're on that plan, we're not. And how do you explain to the parents who say, well, guess what? I'm on Medi-Cal, so how come I'm not getting this, but that other kid is? I mean, that's a really hard place to be. And I'm not sure a lot of school districts want to even be in that place. And that's why I'm sort of saying, in some ways, and this actually, from my perspective, speaks to Medi-Cal services school in general, is that unless, that basically you need to be sure any kid who's on Medi-Cal, at least we can draw a line where if you're in Medi-Cal, you're not in Medi-Cal. But if you're on Medi-Cal, there needs to be a universal system for the school district, so they're not sitting there sorting out which plan you're in. Like either you're on Medi-Cal card, or you're not, and you get the service, right? And then there's some systematic way that they're getting, and by the way, they don't want to have different billing processes for different plans, because again, they're in the education space. They don't want to have a bunch of staff saying, I have to fill out these forms for this plan, that form for that plan. And so in fact, if they're, frankly, I would say is that if they're for school-based services that they might pay for, that you would actually develop a standardized both billing system that's very simplified, and also some sort of because you got to make it really simple at the school district end, because the school district is not a healthcare facility, all right? A clinic, they can develop a whole billing system and so forth because they're providing a whole variety of services, et cetera. A hospital, even a doctor's office. But a school district, we don't want to just have them have a large amount of overhead to figure out how to interface with Medi-Cal managed care plans. So I guess what I'd say is that don't mistake this. I think this is a good idea. I appreciate you providing incentives, but I think in order for it to work, you got to also look at it from the school district's end. So we're going to provide incentives to managed care plans, but for the school district's end, they don't want to sit there and parse out which kid gets this service, which kid gets that service at the school. And I think we do want school-based services. So somewhere at the school-based service level, there's got to be some simplified way to say you're going to get paid for this, that, and that on a fixed fee schedule, so we're not getting paid different amounts for different kids for the same service. And then perhaps the managed care plan has to, so we don't sit there and have multiple some kids on one managed care plan getting services, another one that can't get the same services. So you got a standardized package there. And then of course the managed care plan can also provide, through their own networks and so forth, the non-school based, stuff, because they're going to have referrals to counselors and stuff outside the school, that then they can do their own network or whatever thing. But in terms of their interface with the school, it has to be straightforward and simple. And if we make it too complex, and we're talking about having contracts and things like that, that you have to negotiate individual contracts. Maybe there's a standard contract that's fine, but individual contracts and so forth, you're going to the uptake I think is going to be fairly low. You're going to have a lot of missing school districts, and we're not going to achieve the aims we want to achieve. So I really do appreciate that you're making an effort in this proposal, but just from my own experience and my own knowledge talking to school districts, I mean, after all, let's put it this way. When I was chair of the Assembly Health Committee, I couldn't get DHCS and the Department, I had to force DHCS and the Department of Education to talk to each other about LEA. They wouldn't even meet. I finally got a meeting going. I mean, that's the distance that we're still trying to cross, and things are better now. But I think you really do have to look at it from the school district end, because I think that's where your uptake problem is going to be. And if you don't make the managed care companies do something, be able to do something simple with school districts and something that's consistent across, then unfortunately, I think it's not just in incentives. It has to be a set of sort of a infrastructure that's developed with the user in mind, which is the school district as well, of course, the students in school.
No, I think all your comments are well taken and things that we have been thinking through on our side, because we do know that some of the largest challenges would be for the school district, especially in parts of the state, Sacramento and San Diego, for example, where there are so many managed care plans. We've been trying to think through concepts for how we set up the incentives for if we do require certain players be at the table to receive the incentives for the points that you've exactly made. I think we're continuing to think through those things, and I think would be happy to continue to brainstorm with the legislature in regards to how to make this as successful as possible, because I think we all agree the need is there. I actually think your idea in regards to standard contract and or pieces is very interesting and something that we can take back and continue to think through as this proposal evolves and we figure out how we really can move the needle in regards to getting these services in schools.
Okay, well, I appreciate that. As someone who's been in this space, actually, interesting enough, the project I worked on for with the school district was actually improving care for children with ADHD, again, a mental health issue. So we actually published our results in a journal. I'd be very interested in what your planning is and your thoughts, and how you're also engaging the education community in this to be sure that we have, it's not, because you're used to those, I'm sure the managed care companies are used to dealing with you because you do work. The education community also needs to be engaged to be sure it's workable for them, because you need to have both to make this work. And I'm not saying that you haven't talked to them, but I think that's a very important piece, and I'm very interested in seeing more specifics on how you're planning to roll this out, because I actually want this to happen. So I don't want any of these comments to be viewed as like, oh, I don't think we should do this. But I'm really glad that you're trying to do this, but I also want to see it successful, and I know you do as well. And so hopefully we can share our knowledge and experiences to make that happen.
Yes, we would appreciate those conversations, and we have already done outreach to the Department of Education, and we'll continue to partner with them and look forward to partnering with you.
Thank you very much. Okay. Now I believe we're moving on to issue number 18, Mental Health Services Act flexibilities.
Yes. As a part of the 2020 Budget Act, AB 81 allowed for temporary flexibilities for counties due to the public health emergency. It allowed counties to spend down their local MHSA prudent reserves as opposed to submitting a request to DHCS. It allowed counties to spend clinical service and supports program funding regardless of subcomponents. Allowed counties to use their current approved 3-year plan or annual update if the behavioral health director certifies that they were unable to submit a new plan due to the public health emergency. It also extends the reversion deadline for the unspent county funds subject to reversion as of July 1, 2019 to July now 2021, and allows DHCS to achieve the above through bulletin authority. So this would allow DHCS to expend the current flexibilities for another year, given the ongoing public health emergency, and happy to answer any questions that you have.
Department of Finance? LAO? Dr. Pan? No. I think this makes sense to all of us. Moving on to issue number 19.
So here, DHCS is requesting approximately $1 million for 2-year limited term contractor resources to provide user acceptance testing and technical support to county mental health plans, drug Medi-Cal, and DMC ODS to implement health provider directory expansion. The Health Provider Directory Expansion Project is a department-wide initiative to standardize the format, content, and transmission of Medi-Cal managed care provider network data to the department, and we are expanding that to our behavioral health counterparts. I'm happy to answer any questions.
Department of Finance, anything? LAO? No? Dr. Pan? No? No? We're smart to put these faster ones at the end. Okay. Number 20.
Yes. Here, the department is requesting expenditure authority to implement the assisted outpatient treatment program, expanded statewide beginning January 1, 2021, unless a county chooses to opt out through their Board of Supervisor approval. Participants in the assisted outpatient treatment are individuals with serious mental health illness and who are at risk of institutionalization or would otherwise be served in an institutional setting. And happy to answer any questions regarding this request.
Department of Finance? LAO? Sounds like a fine idea. Dr. Pan?
Yeah, I just want to say it's very important that we fund implementation of an outstanding bill.
All right. 21.
All right. So here, sorry. The department is requesting 4 positions and expenditure authority of approximately $600,000 to implement SB 406 by taking action on complaints against recovery residents associated with licensed facilities that provide unlicensed SUD treatment services. Positions would be used to develop and implement regulations, protocols, compliance reviews, and to investigate complaints. And happy to answer any questions.
Department of Finance? LAO? I think this one. No, this one makes sense also, Dr. Pan?
I just, again, appreciate the proposal. I do want to acknowledge, even though in the analysis, it was a committee bill, like Fire Health, in that we included a provision, these provisions relate to Senator Bates. So I want to recognize that this was Senator Bates' implementation, and certainly happy to have to see this move forward. Thank you.
Thank you very much. All right, and I think that concludes the items that we've been talking to. We certainly, we're going to go to public comments now, but we certainly thank you for all the time that you put in both today as well as all year long and in preparation for this. Also to the Department of Finance and LAO, we appreciate your hard work. If we could now, we're going to, again, hold everything open for now, but we're going to move to anyone waiting to provide public comment. And as a reminder, today's participant number is 844-291-6364, and the access code is 1417609. Due to time constraints, I'm going to ask callers to please keep your call to 1 minute. Identify yourself, and then we'll go on 1 minute, and then we'll be moving on. Are there any witnesses in the hearing room? I see none. Okay. And then now we'll move to the teleconference line. First caller, please.
As a reminder, if you wish to make public comment, please press 1 followed by 0. And you will also want to mute your webcast while your phone line is open. Madam Chair, are you ready for the first comment?
I'm ready.
Thank you. We'll go to line 28. 28, please go ahead.
Thank you. Ryan Spencer on behalf of OCHIN and the California Telehealth Network regarding issue number 8. OCHIN's network of community clinics includes 32 California members, serving nearly 1.5 million network patients, half of those receiving care under Medi-Cal. In 2020, organizations within the OCHIN network received over 2.8 million unique visits in California, and as a result, direct result of the telehealth flexibilities and expansion throughout 2020, 37% of those encounters were conducted using telehealth, the majority in primary care services. Telehealth has been essential to advancing healthcare equity. For example, approximately 47% of OCHIN's California network patients are Hispanic, and 31% are over 50 years of age. Of these patients' encounters, 45% were delivered in a language other than English, with 3 out of 4 patients served in Spanish. OCHIN strongly supports continuing the telehealth flexibilities, particularly ensuring payment parity in all settings, including FQHCs. Especially crucial is parity for audio-only appointments, since about 26% of OCHIN's telehealth visits were audio-only, most of which were behavioral health services. Bottom line, individuals who face access barriers to in-person care have been able to receive care via telehealth during COVID-19. Patients who stated they needed housing and transportation support were 14% and 17% more likely to use telehealth, respectively. The continuation of parity and expanded telehealth coverage, including audio and services from FQHCs, is essential in order to maintain access to care for high-risk and rural patients throughout the state and help many others overcome common healthcare barriers such as work, transportation, childcare beyond the pandemic. Thank you for your time.
Thank you very much. Next caller, please. Please try to limit your comments to 1 minute.
We'll go to line 16. Your line is open.
Madam Chair and members, it's Roxanne Gould. In the interest of time, I'm calling representing the American Nurses Association of California and the California Association of Clinical Nurse Specialists in support of item number 9.
Thank you very much. Next caller, please.
Line 40, your line is open.
Hello, Madam Chair and Senators. This is MJ Diaz on behalf of SCIU California, here to share quick comments on the administration's CalAIM behavioral health and telehealth proposal. First, on CalAIM, we appreciate some of the slight changes in the second proposal, ensuring that there is level of continuity by requiring managed care plans to contract to county whole person care providers. But we would still like to emphasize the role of our county workforce, especially their skills and knowledge of locally available resources to make timely and direct referrals connecting people to critical services. We still have a lot of questions on the managed care plan's abilities to either provide these services in-house or who they end up contracting out to as ECM lead care managers in the future. Second, on the behavioral health set of investments, we generally support the $750 million investment as well as the $389 million investment on student mental health. Although for the $750 million, we'd like to also request that this funding could be used towards improving and upgrading existing IT systems in our behavioral health delivery system in order to build out linkages for data so that we actually know what beds are available and what related services are provided or could be provided by hospitals and psychiatric facilities. And lastly, on telehealth, we are also generally supportive of expanded access to care, but want to make sure that this is additive and it would not hopefully impact or eliminate existing workforces. Thank you.
Thank you very much. Next caller, please.
Line 59, your line is open.
Thank you, Madam Chair and members. This is Sarah McDade-Ting on behalf of the California State Association of Counties. I'm going to run through. There's 5 issues that we were monitoring today, and we appreciate your time on all of these. We appreciate on issue 2 the COVID response for DHCS. We appreciate that DHCS has turned on a dime, a veritable dime, throughout this entire pandemic, and just the partnership has been great thus far, and that's something that I haven't been able to say for a long time. So wanted to make sure that the committee was aware of that. On issue 5, CalAIM, we're broadly supportive of the whole CalAIM effort. Of course, the devil will be in the details, including how plans plan to outreach to members or prospective members. So again, we're working closely with DHCS and our affiliate partners in that area. On issue 16, the behavioral health, the governor's proposal for investing $750 million into the behavioral health housing continuum. We're strongly supportive of that issue. We also are supportive of issue 18, which is the MHSA flexibility. And we are pleased to support issue 20, Madam Chair, the implementation of AB 1976 with some additional staff for DHCS to help with that workload. And lastly, 2 issues that came up during the hearing but weren't on the agenda, the quality improvement funding that Ms. Cooper mentioned. For counties to get better data to better track outcomes. We're strongly supportive of that. And then we're supportive of the OIG recoupment. You heard from Department of Finance, Ms. Ramos, talking about the recoupment. We have asked that the state defer that recoupment for the current year and are in talks, of course, with the administration and others about that.
Okay.
Again, I want to thank this committee on behalf of all 58 of California's counties.
Okay.
Thank you.
Thank you. Thank you. Next witness.
Line 6161, please go ahead.
Good afternoon. This is Kelly Brooks. I will be commenting on 4 proposals on behalf of 4 different clients. First, on CalAIM, I'm testifying on behalf of the California Association of Public Hospitals and Health Systems, the County Health Executives Association of California, and the Urban County Caucus. CalAIM is critical for the public healthcare system and counties leading whole person care pilots under the 1115 waiver. As the pilots come to an end, CalAIM proposes to sustain and expand upon the important whole person care management and wraparound services by incorporating them into Medi-Cal managed care. Adequate financing and robust collaboration between public hospital systems, counties, and managed care plans will be essential to ensure a smooth transition. COVID has underscored the critical role that counties and public hospital systems have in serving the most vulnerable, and that value should be leveraged under CalAIM. Lastly, the timeline is incredibly ambitious. We must closely monitor local implementation readiness and adapt as needed. Second, on the issue related to telehealth, I'm testifying on behalf of the California Association of Public Hospitals and Health Systems. Telehealth has been absolutely critical for public healthcare systems during the pandemic. Many patients have come to prefer connecting with their providers via telehealth, and that will still be true post-pandemic. Video visits are not a viable option for many of our patients, so audio-only phone visits have been a critical modality, and we must continue to allow in the Medi-Cal program to ensure equitable access to care. Phone visits can be a good substitute for certain types of in-person visits, and when the same standards of care are met, we believe payment should be the same as if it had been in person. We look forward to continuing to work with the department on this important access point for patients. Next, in regards to the $750 million proposal for behavioral health infrastructure, both the urban counties of California and Riverside County support that proposal. And finally, on behalf of Riverside County, I wanted to mention they are looking very closely at the student behavioral health proposal that received a lot of conversation this afternoon, and trying to figure out how that proposal complements some of the existing work that is going on between school districts and county behavioral health. And we look forward to receiving more information in detail. Thank you.
I appreciate it. Oh, thank you.
Thank you very much. Next caller, please.
Line 6363, please go ahead.
Hi, thank you, Madam Chair and members. Kathy Sunderling McDonald for the County Welfare Directors Association. First, I'd like to associate CWDA with the comments regarding whole person care that were made by the prior speaker, Ms. Brooks-Lindsay. Additionally, we really appreciate the conversation on items 2 and 3 related to Medi-Cal caseload, as well as what happens when the public health emergency is lifted with regards to our county eligibility staff processing cases that will have been in some cases not looked at for 2 years or longer. We are working closely with the state, as they noted, have provided some thinking, and we'll look forward to working closely with them, as well as engaging in advocacy at the federal level to ensure that the federal Centers for Medicare and Medicaid Services provide sufficient time for states to process these cases that have been put on hold during the pandemic. Thank you for your time.
Thank you very much. Next caller, please.
Line 64, your line is open.
Thank you, Madam Chair and members. Vanessa Kahina with KP Public Affairs on behalf of the California Academy of Family Physicians. On CalAIM, we applaud the department's commitment to improving quality and outcomes, reducing disparities, and transforming the delivery system. These were not themes that we discussed even just 10 years ago, and DHCS should be commended for incorporating those principles into healthcare policy for very vulnerable individuals. We appreciate the committee's questions regarding oversight of managed care plans as they take on more and more responsibilities for these patients with complex conditions, and we urge the committee and DHCS to premise value-based payments and primary care as a pillar in these reforms. This includes greater oversight of contracted plans down through their delegated entities where there can still be a mix of fee-for-service payments and contracts. Value-based payments support patient-centered continuous care, and any transformation in Medi-Cal delivery must integrate this as a means to better care for Medi-Cal beneficiaries. In regards to the administration's telehealth proposals, we're at a transition point from immediate response to new COVID-19 normal, and clinicians need the allowances we have today to continue treating their patients in the most effective ways possible. CEFP supports efforts to expand and make permanent telehealth flexibilities authorized under COVID-19 for both private and public payers. This includes payment parity for in-person face-to-face visits and synchronous telehealth in both Medi-Cal fee-for-service and managed care, and to add remote patient monitoring. Tremendous progress and investments have been made by providers into telehealth, and the ability to be reimbursed for telehealth, including those telephonic modalities, regardless of provider type, will keep the ongoing health of our communities at the forefront, as well as on practice viability. Thank you.
Thank you very much. Next caller, please.
Line 6565, please go ahead.
Good afternoon, Chair. This is Lisa Coleman with the California Long-Term Care Ombudsman Association, and I'm calling in support of item number 11. I want to make this just real for you as a story. Imagine you are a long-term care facility resident, and something happens and you are sent to the hospital, and you want to go back home because you consider that skilled nursing facility your home. But for some reason, they've decided they don't want you to come back. So while you're in the hospital and not feeling well, you muster up the energy to go to the Office of Administrative Hearings, and you go through the appeal process. And you win. You get a piece of paper that says that the facility couldn't demonstrate why you aren't a good fit. But that piece of paper means nothing because there's no stick associated with that piece of paper. So now you have to go to the Department of Public Health and you have to plead your case again. And this committee heard just last week from the department on how long sometimes it takes for those complaint investigations to be resolved. And you heard today from Director Lightbourne that more often than not, the facilities are not able to win those hearings. The residents do, in fact, win most of those hearings. So we are very much in support of this proposition or this bill proposal, but we would ask that you put a little bit more teeth to it. Why are we waiting till the 6th day to add the stick? Why not make that $1,000 fine happen within 2 days? And let's go even further. When a resident has been denied access to their home, and the hearing has proven that the facility has no legal right not to bring them back, and they've spent their 100 days and they've accrued their $100,000 fine, and they're still not willing to bring the resident back, why don't we go further and give the department the authority to prohibit any new admission until that resident is readmitted, starting on that day 101. So the ombudsmen are very much in support of this bill, and we thank you for your support also.
Thank you very much. Next caller, please. And again, please try to keep your comments to 1 minute.
66, please go ahead.
Good afternoon. Linda Way with Western Center on Law and Poverty. Do have comments on 6 different issue areas. Firstly, we shared the LAO's questions regarding the administration's Medi-Cal caseload projection, noting that last year's projections have not borne out and applications are still lower than 2019. Regarding issue 5, we appreciate the work in developing the CalAIM proposal, but remain concerned about plan capacity for care management as they are unable to meet current obligations. Prior to mandating plan enrollment and giving plans additional responsibilities, we have consumer protection recommendations, including plan readiness, that we'll share in writing. Also, we request housing support services be a statewide benefit administered through the county or phased-in ECM benefit. Regarding issue 6, we support the delay of Prop 56 funding suspension and request eliminating the suspension completely, specifically for critical Medi-Cal benefits and postpartum eligibility. Regarding issue 8, we support the expansion of telehealth in a way that honors consumer choice, but have concerns with efforts to weaken consumer protections through TBL that extends alternative access standards from annual to 3 years. We support issue 9 to make continuous glucose monitoring a Medi-Cal benefit, and issue 10 to implement the CCT program. And finally, regarding issue 17, we support increased access to student behavioral health services and share the LAO's recommendation for TBL for better oversight and accountability. Thank you.
Thank you very much. Next caller, please.
Line 55, your line is open.
Line 55.
I believe
line
that's your
55?
line.
Oh, is that me? Am I in committee?
You have 1 minute, ma'am, to make your comments.
Oh, well, but the other callers were getting 2 to 3 minutes. Is this Senator Eggman?
Ma'am, you have 1 minute to make your comments. Please proceed.
The Pfizer, NASDAQ, PFE, and Moderna, NASDAQ, GS, mRNA vaccines are both mRNA treatments. The COVID shot is not, by definition, a true vaccine. It is mRNA technology that has EUA, emergency use authorization only. Both of these companies are traded on Wall Street with hedge funds being the main shareholders. They function, these shots, by reprogramming the recipient cells at the cytoplasm level. Not only are the COVID vaccines unproven, the treatment itself, mRNA, is only a few years old. The entire human population is being asked by the Wall Street media feedback loop to be genetically reprogrammed by a new experimental treatment of questionable efficacy that causes serious side effects, including death, all for a disease that has a 99.9% survival rate. What could go wrong? And where is Dick Pan? Why did he leave this hearing?
Thank you very much, ma'am. Next caller, please.
Item number.
Next caller, please. Thank you very much.
Line 68, your line is open.
Good afternoon, Madam Chair. Awad Kadani with Lang, Hansen, Giroux, and Kadani, representing the California Children's Hospital Association. Want to comment on two issues. Regarding issue 8, the Children's Hospital Association is excited to see the administration is looking to make many of the telehealth flexibilities adopted during the pandemic permanent. These flexibilities have been a lifeline for many of the children and families that are suffering during these times. However, going forward, we would like to ensure that pediatric providers will continue to be reimbursed for the care they provide from outside the four walls of the hospital and hospital-based clinics. Secondly, Madam Chair, we look forward on issue 9. We welcome the extended coverage on continuous glucose monitors for adults, as it allows for better continuity of care for CCS youth as they age out of the program. With that, I thank you, and that's all my time.
Thank you very much. Next caller, please.
Line 36, your line is open.
Hi, can you hear me?
Please proceed.
Can you hear me?
Yes, I can hear you. We can all hear you. Go ahead, please.
Okay. My name is Amy.